My name is Shaun McCann. I'm conducting some expert interviews for the European Hematology Association at the annual meeting of the American Society of Hematology, which this year is in Orlando in Florida. And with me I have David Kurtz. You're very welcome. Thank you for coming along.
Good to meet you. Thank you for having me.
Not at all. David is an instructor in the Division of Oncology and Hematology at Stanford University in California, which is in the USA, obviously.
It sure is.
And he studies and is an expert on circulating tumor DNA. And first of all, as I said to you before, I think it's a minority sport. Not too many people know too much about it. And I'm going to say something quite provocative to start with. I went to a meeting about 25 years ago when they were talking about circulating DNA for tumors. So are we any better? Are we there yet, as the kids say?
I think we're getting there.
Okay.
I think we can say that we've made a lot of improvement over the last decade or two. So this has been an active area of research over the last, really, as you say, 25 years. Part of the field of liquid biopsies, trying to develop technologies to track malignancies, including blood cancers, non-invasively from the blood plasma. And over the last 5 to 10 years, I think that the technology has come a long way with the advent of a lot of the newer next generation sequencing approaches and a lot of methods to detect lower and lower levels of disease burden. And I think that technologically we're there. I think we have a ways to go in terms of standardization and trying to apply this technology to patients in the clinic.
Obviously, the idea of a venous blood sample is very attractive to most people, rather than a very expensive or invasive investigation. Are there any particular tumors that you think would be the most productive in terms of your research?
Yes, I think there are. So circulating tumor DNA, just for the uninitiated, is really a small fraction of the total cell-free DNA. So if you take a blood draw from you or from me, and spin the blood draw down and take only the plasma, and you can isolate DNA from this. And there's a low amount of DNA in that blood plasma sample, maybe 5,000 or 10,000 cells worth per milliliter. Circulating tumor DNA is a small fraction of that small amount of DNA. And one of the things that we found is that detecting these tumor-derived molecules through somatic mutations that define the patient's malignancy, depends on the number of mutations that you can track. So my research has primarily been looking at circulating tumor DNA in B-cell non-Hodgkin lymphomas, which, as you may know, has a number of mutations in it due to the ongoing somatic hypermutation that drives our immunoglobulin and antibody diversity. So in particular, B-cell lymphomas are a very attractive source, a very attractive disease to detect and track using circulating tumor DNA. Okay,
let's just talk about NHL then for a minute or two. What about clonal evolution with these tumors? I mean, do things obviously change over time? Is that a problem for you?
Yeah, absolutely. And I think it depends on the disease. So our very aggressive malignancies, which most of my research has been in, diffuse large B-cell lymphoma and primary mediastinal B-cell lymphoma, when we look over time in patients that have disease and then have their disease treated and go away in the circulating tumor DNA, and then their disease re-emerge, it tends to really be an almost identical clone in terms of the mutational profile.
That's reassuring.
So there can be resistance mutations. Maybe if you get ibrutinib, maybe you would develop a mutation in BTK. But the other hundreds of mutations that we see are all the same.
Okay.
I think that is not necessarily the case in low-grade lymphomas, such as follicular lymphoma, potentially CLL and SLL, where the disease has more time to evolve and develop these new mutations. Right. And so I think that is an active area of ongoing research. And so it's a matter of, in my mind, I'll look at it as a glass half full, where it's a matter of what can we learn and how can we use the circulating tumor DNA as an opportunity rather than a detriment.
Right. So are you at the stage now where you're ahead of the sort of classical way of diagnosing these diseases, or not?
Yeah. So I think in some senses yes, and in some senses no. So I think the screening question is very hard. A number of companies are tackling this, trying to screen patients for undiagnosed cancers. primarily more in solid tumors, but some work in blood cancers as well. I think where we have a potential advantage is in looking for patients at their response to therapy. So I think that we have some data that was published in Journal of Clinical Oncology that suggests that circulating tumor DNA may be a better tool than interim PET CT scans for identifying patients who are responding to therapy, primarily due to the specificity of the assay, and also looking at patients who may be at risk for disease or relapse after the completion of therapy. So I would say some places yes, and some places there still is work to do.
Right. I mean, screening is a very emotive subject, and most people don't know what it means anyway. Yeah. But I'm not sure we want to go down that road. But let's say you're following a patient who's been treated.
Yes.
I mean, what sort of intervals are we talking about now?
Yes. So I think what we've seen in terms of a patient who's been treated who's in a remission, what we've seen in lymphomas as well as lung cancers and breast cancers is that we can get somewhere between a 5 and a 10-month lead time over the clinical or radiographic reemergence of a disease. So a patient who has no disease on their PET CT scan, and we are tracking their circulating tumor DNA, let's say at every 3-month interval, we will see that circulating tumor DNA turn positive somewhere between 5 to 10 months before their eventual clinical relapse.
Okay.
So I think that interval can tell us how frequently we should potentially be doing this test. And somewhere between a 3-month or a 6-month interval, I think we would potentially be able to catch patients who are having the disease relapse earlier.
Right. Any potential ethical problems in that?
Yeah. So I think that this is one of the big questions about translating this assay into the clinic is what do you do about finding this molecular evidence of disease, which we as scientists believe means relapse every time, but these
not necessarily.
Exactly. These are studies that have only been done in low numbers of hundreds of patients. Yeah. So is it ethical to detect disease and then not intervene on that patient at that time? I think that's one question: is what do you do about the reemergence of this circulating tumor DNA? And that's where we need the clinical studies, I think, to really drive how we can improve outcomes with this technology.
Okay. Let's just go back again to the tumor types, because you mentioned obviously non-Hodgkin's lymphoma, but there must be other tumor types. I mean, is there a commonality in type or where they are, or you know, what makes them shed tumor DNA?
So we found a number of things that drive the concentration of circulating tumor DNA in the blood plasma. So certainly the compartment of disease can determine the concentration of circulating tumor DNA in the blood plasma. So as it turns out, hematologic malignancies, because the cancer is right there in the blood, are a pretty good group of diseases to track circulating tumor DNA. In contrast, circulating tumor DNA levels in colon cancers and lung cancers are quite a bit lower. And in particular, some diseases such as pancreatic cancer and prostate cancer, which have this dense stroma and poor vascularity, are very challenging to use circulating tumor DNA to detect or monitor a patient's disease. So I do think that this is not, I think we can apply this technology to a lot of cancers, but may not be the ultimate solution for every cancer. Right. It's unfortunately not the panacea for every disease, but maybe for a few select ones.
Nothing ever is. Okay.
Yes.
Okay, so let's talk about the technology. I mean, how difficult is that, and what precisely do you do?
Yes, so I work on a technology called CAP-seq, or Cancer Personalized Profiling by Deep Sequencing. And this is essentially, it's a lot of big words, but it is essentially a targeted hybrid capture sequencing approach where we capture a small fraction of the entire human genome. So if the whole human genome is 3 billion base pairs, we capture about 1/10,000th or 300,000 base pairs, where in particular non-Hodgkin lymphomas are recurrently mutated. And we sequence that to ultra-high molecular depth. So for every, let's say, BCL2 molecule, which is frequently mutated or translocated in lymphomas, we will sequence 10,000 or 20,000 copies of BCL2, trying to find a very low level 1, 2, 5 molecules of those 10,000 that contain the mutations of interest. Right. So this is pretty challenging. This is pretty high-tech stuff. So as you can imagine, there's a lot of error in next-generation sequencing even today. And so we apply a lot of bioinformatic frameworks, a lot of molecular biology frameworks to move the level of noise lower so that we can detect lower and lower levels of disease.
Okay. So this is not applicable to diagnostic laboratories yet anyway, is it?
Yeah, so there are companies who are doing this already more in solid tumors than in liquid tumors. But it's similar to the technology that Guardant 360 has, and they have an assay primarily, again, for solid tumors. Foundation, which is one of the targeted next-generation sequencing companies for tumors, of course, have a cell-free DNA assay as well. And Roche has also gotten in the game as well. And they're reporting their experience in the research setting in non-Hodgkin lymphoma using a very similar approach to our own. And I think that in the next, I would say in the next 1 or 2 years, you're going to start seeing these assays become available for maybe not for routine clinical use, but as integrated biomarkers into clinical trials.
Okay. I came across the word beaming. Can you tell me what that means in English?
Yeah, absolutely. And I actually can't remember the acronym for it, but I can tell you what it is. Okay. So circulating tumor DNA, there's many ways to skin a cat, as it were. So circulating tumor DNA, as I mentioned, is just detection of this small fraction of tumor-derived DNA that has somatic mutations in the blood plasma. So you can do that by next-generation sequencing. That's what we do. But you also can do it by PCR-based approaches. Yes. And so beaming is essentially a digital PCR-based approach. Many people are familiar with quantitative PCR, where we try to use fluorescence to enumerate the number of DNA molecules of a target of interest. Beaming and digital droplet PCR are essentially more sensitive versions of that same assay, where we can try to put each DNA molecule into a droplet or onto a bead, do PCR on that DNA molecule, and then have thousands of copies of each DNA molecule and enumerate how many are positive for our mutation of interest using fluorescence. So long story short, I would call it an ultrasensitive quantitative PCR method.
Right. So it's a ratio of the specific mutation versus the background noise.
Correct.
Okay.
Now with beaming or with digital droplet PCR, you can only evaluate a few alleles at a given time. So these are really useful methodologies when your cancer is defined by a specific mutation. Yes. You can think of, for example, hairy cell leukemia, BRAF V600E, every time they have it. Waldenstrom's macroglobulinemia, MYD88 mutation, every time. So these approaches are actually fantastic. They're cost effective, they are sensitive, and because you know exactly what mutation you're looking for, they work great.
But they're rare diseases.
Exactly. So a disease like non-Hodgkin lymphoma, which has a lot of mutations, but they aren't always the same mutation. Not every case will have that MYD88 mutation. Not every case will have that CREB-BP mutation. So you need to look at, in those scenarios, a broader panel to find mutations to track in every case. It's a matter of applying the right technology to the right disease.
So you would take the tumor cells from the biopsy or whatever initially and look, and then track that. Am I on the right track?
Yeah. So that's the technology that we were doing, I would say, 3 or 4 years ago. Yeah. So starting with sequencing a tumor sample, identifying the disease-defining mutations, and then going to a blood plasma sample and tracking those same mutations over time. What we found, in particular in non-Hodgkin lymphoma, is that the burden of tumor-derived mutations in the blood plasma prior to therapy is so high that you actually can just sequence the pretreatment plasma. Right. So, for example, for an average patient with diffuse large B-cell lymphoma, almost 5% of all the DNA molecules in the blood plasma prior to therapy will be tumor-derived. Right. For example, in a limited stage lung cancer, that may only be 0.5%, a full 10-fold lower. So today, my lab currently, for the most part, if you can give us a tumor sample, great, we'll use it.
But you don't always have that.
Well, we don't always have that. You always have that luxury, and so we will just sequence the pretreatment plasma and identify the mutations just right off that blood plasma.
And that's your
sample.
baseline.
Exactly, that's our baseline, and then we use that to then track the mutations over time. And we can do pretty well. I think we can identify disease quite frequently when the PET scan is negative. Although there are many patients who we have where the circulating tumor DNA test is negative, and they still eventually relapse.
Yes.
So technological improvements are still relevant and still important moving forward. I'll put a shameless plug in for an abstract I'm presenting tomorrow morning, where we'll talk about a technology improvement that we think we can get another log-fold lower to get us down to the order of parts per million for detection of ctDNA.
So it's a bit like minimal residual disease.
Absolutely.
Which is, again, a highly controversial area.
Absolutely. I think that's a great analogy for circulating tumor DNA. In CML, we have BCR-ABL transcripts. We can use that from cells and track MRD. CLL, you can use flow cytometry. In the case of non-Hodgkin lymphomas, unfortunately, our disease does not circulate. So how can we track minimal residual disease? And I think this plasma-derived circulating tumor DNA might just be the thing for us.
Okay, so thank you very much indeed for sharing your thoughts with us.
Yeah.
And for your young investigators out there, as David said, there's still a little bit of work to be done before this becomes really a useful and obviously predictive assay, but very attractive if it can be done on a plasma sample.